It is not the first time that I hear this, but it has come to my attention again that my colleagues will only consider taking a course or learning a new approach if it's evidence-based. I would like to discuss the consequences of this choice, what evidence-based medicine was and now is, and what it should be. And aren't you really interested in the magic coming out of the chambers of the pyramids of evidence? Aren't you interested in the expert opinion of those who've been in the field for more than 40 years? The ETT Skin Approach taping methods is sufficiently backed by evidence, and the fact that colleagues, educators and science don't know this is a shame. My name is Esther Deroux. I have been a physiotherapist since 1977. I've specialised because we have such a wonderful profession in lots of areas, and I've certified in quite a number of different techniques. I've worked in Germany, Spain, Belgium and in the Netherlands, being chair of the committee practice of the IOPTP, the International Organisation for Paediatric Physios of the WCPT, and developed the ETT Skin Approach taping courses, authored a book, and moderate Facebook pages about taping and scoliosis, and moderate a number of professional special interest groups on Facebook and LinkedIn. Did you know that there are 195 countries in the world? Did you know that most of the research comes from colleagues living in approximately 10 rich Caucasian countries, most of them with a colonial background? Did you know that the evidence-based medicine as described by Sackett has been completely misunderstood and misused, and that the evidence-based Renaissance Group has stated this and made suggestions how to change in 2014? Did you know that the traffic light articles, the result of taking only one pillar of the evidence-based medicine, 3 pillars into account, has caused fierce discussions and has been seen as detrimental for the development of our profession by many? And did you realize that new methods and approaches can really work quite well without any research having been conducted to their effect yet? According to the members of the Evidence-Based Medicine Renaissance Group, the evidence has been misappropriated by vested interests. The volume of the evidence, especially the clinical guidelines, has become unmanageable. The statistically significant benefits could be marginal for us in clinical practice. And all these inflexible rules and technology is producing care that is management-driven rather than patient-centered, and that evidence-based guidelines often poorly map and poorly heed the people with complex multi-morbidities. According to this group, real evidence-based medicine should make the ethical care of patients top priority. It should be individualized and characterized by expert opinion. There should be shared decision-making, and it should build on a strong clinician-patient relationship, and also apply this principle at a community level. They suggest the following actions are needed to deliver the real evidence-based medicine in this world at this time, although we're talking 2014. First, the patient must demand better evidence, better presented, better explained, and personalized. And clinical training must increase the expert judgment and shared decision-making skills. Purposes, tools, evidence summaries, anything that is produced must take into account those who will be using them. Publishers should demand that studies not only meet all sorts of wonderful research standards, but also usability standards. And policymakers should resist the fact that the use of evidence to their interest. Independent funding should increase, and the agenda should be much broader and much more interdisciplinary. Because even though there's still a lot of emphasis on the evidence-based medicine, as in the evidence, it needs to be evidence-based as in scientific evidence, please, colleagues, do not forget that our profession is not a modality. There are way too many variables in what we do, how we treat, the variety of disorders, how we interact with our patients, how we take their fears and worries into account. This all adds up to a very difficult subject to research. Too many variables. Because when you really think of it, our pyramid, our evidence-based pyramid as we know it, excludes many from all the research and is built on a large subterranean cellar full of excited professionals, colleagues on a journey of discovery, enduring, experimenting and implementing what works. And is this pyramid of evidence, as it has been presented for such a long time, is this most relevant to educators and researchers? But have they forgotten about the cellars, about where the work starts and where the hard work is done? Deciding not to go to courses that are or follow new approaches that are not evidence-based yet means you are missing a lot of development. And isn't it an enormous pity that people like Judy Carmick, who's developed the TACEs 20, 30 years ago, Beverly Kusik with her teratogs, Susan Blum with her total motion release, all these people, experienced clinicians, have developed and are still not taken as seriously as they should be because it's not all evidence-based. And this is where I come in, because having developed the skin approach to the use of elastic tape therapeutically, I can tell you it is pretty evidence-based in the meantime, especially if you take the skin into full account. And it has been shown to be effective in people of all ages, from the neonate to the elderly patient. And yet everybody says it's not evidence-based, so people are ill-informed as well. Many of you will know elastic therapeutic tape as kinesio or kinesiology tape. It's tape that mimics the skin and has been applied to paper with a light stretch. The elasticity varies from 30 to 40%, and it stretches along its longitudinal axis only. We now have hundreds of brands with all wonderful colors, and they are all very similar but do differ a little from the kinesio tape, the original kinesio tape. The interesting thing is that research has shown that the mechanical properties, the glue and adhesives, are not the same, not even in different colors of one brand. And the adhesive is unknown, which is pretty bad. Knowing this, with all these variables, that means we need to recommend one brand and one color when doing research, and we need to state brand and color when we are doing research and in our patient notes. Not only are there many brands, but there are also many methods for the way people use tape. The original one was kinesio taping. It was soon followed by something called the kinesiology taping. But these are all the names that I've been able to find about the different methods that do not all tape in the same way. As stated earlier, the skin approach to taping is based on a lot of science and research, and there are many studies about how and why tapes works on the human body, and they are quite interesting studies. A summary of these research areas is on this slide, and yes, the ultrasound imaging, the fMRIs, the MRIs, ECGs, EEGs, blood samples. There's a lot of different people have looked with different eyes at tape and what it does in the human body. I'm very thankful to our colleague, Professor Fukui from the University of Tokyo from Japan, that I'm allowed to use his ultrasonic imaging images of an ultrasonic probe being put halfway the thigh of a person sitting on a bench, extending and flexing their knee. So that's what we're looking at now. Now, the epidermal layer is quite large. The white areas, the fascia, is the fascia around muscles. And as you can see, the skin moves in one direction and the muscles do move in another. So there is movement of both. What we did was copy this research in the clinic where I worked at the time with an orthopedic surgeon. He applied his ultrasonic imaging probe on the leg. I stretched the skin up and would let go while he was looking at what was happening in the leg. And of course, you could use a tape to have the same effect, because that is, of course, what we would like to prove. And what you are seeing now is the effect of skin stretch there and the patient not moving. So the skin is being stretched and let go, and there's definite activation of motor units. There is proof, and this is not the only study. I've repeated this study, and you can find that on Facebook and one of the Facebook pages I manage. We've repeated it with different images. Another study I would like to talk to you about shortly is this MRI analysis showing that kinesiotape has an effect not only locally but also more distantly. Pamuk and Yukasoi are engineers, and they looked at the idea of, Kenzo had said we have a skin lifting property of the tape. They wanted to discover if that was true and if something else was happening in the leg in the meantime. So a leg was placed into the MRI, the whole lower extremity, and the tape was applied to the skin on top of the tibialis anterior, and they measured reactions. Of course, the strongest reactions near the tape, but in the whole limb. They not only found skin lifting, but skin compression as well, showing that yes, not only immediately in the targeted area, but also at a distance, tape has a physiological effect. So please, colleagues, open your ears and your eyes and your heart to the news coming from our colleagues in the subterranean chambers. Regarding the elastic therapeutic taping, you are welcome to respond and ask questions and send me an email or check the Facebook pages. You're welcome to read all the clinical notes and articles published on Academia Edu and on ResearchGate. And for those colleagues thinking that elastic therapeutic is not evidence-based, the skin approach, I would like to challenge you to go into a debate with me because you think I'm terribly wrong. I hope that this little video has made you rethink, made you more open to learn new stuff, because if you are going to rely on guidelines, that means you are going backwards in time. It takes about 20 years for something new to get into a guideline. Please don't go backwards. Go forwards and challenge me. Wishing you all the very best.